Hello everyone. We are going to discuss about drug affecting renin angiotensin system, and we are going to cover the subtopics that are angiotensin converting enzyme inhibitors, other ACE inhibitors, its uses, angiotensin antagonist, uses of ARBs, and direct renin inhibitors. Now, angiotensin converting enzyme inhibitors. Introduction. ACE inhibitors is an agent which block angiotensin converting enzyme which ultimately inhibits conversion of angiotensin 1 to conversion of angiotensin 2. Drugs: captopril, lisinopril, fosinopril, enalapril, quinapril, perindopril and ramipril. First, captopril. It is prototype drug. Captopril lowers BP but in short-term magnitude of response depending on sodium status and level of RAS activity. Pharmacokinetics. About 70% of orally administered captopril is absorbed. Presence of food in the stomach reduces its viability. It is partly metabolized and partly excreted unchanged in urine. Plasma half-life is 2 hours. Now other ACE inhibitors: enalapril, lisinopril, perindopril, fosinopril, ramipril and imidacloprid. Now enalapril. It is the prodrug not used orally because of poor absorption. Its absorption is not affected by food, has longer duration of action, rashes and loss of taste are probably less frequent. Second, lisinopril. Lysine deactivates of enalapril. Oral absorption slow and incomplete but unaffected by food. Perindopril. Long-acting ACE inhibitors with slow onset of action and good oral absorption. Fosinopril. The ACE inhibitor is unique in being a phosphonate compound that is glucuronide conjugate and eliminated both by kidney and liver. Ramipril. Ramipril is long-acting ACE inhibitors. Imidacloprid. The oral viability of this long-acting prodrug ACE inhibitor is 40%, which is reduced by taking drug with meal. Uses: hypertension, congestive heart failure, myocardial infarction, scleroderma sclerosis, crisis, diabetes nephropathy. Uses: hypertension, mild or moderate hypertension, first line drug. Hypertension emergency, IV enalapril is preferred. Hypertensive emergency, oral captopril is preferred. In congestive heart failure, ACE inhibitors causes both arteriolar and venodilation. In CHF patients, reduces afterload as well as preload. ACE inhibitors reduces mortality. Myocardial infarction, unstable angina or non-ST segment elevation MI, long-term ACE inhibitors used. Therapy reduces recurrent MI and need for coronary angioplasty. Oral ACE inhibitors administered while MI is evolving and continued for 6 weeks reduce early as well as long-term mortality. Fourth, scleroderma crisis. The marked rise in BP and deterioration of renal function in scleroderma crisis is mediated by angiotensin 2. Fifth, diabetic nephropathy. Prolonged ACE inhibitors therapy has been found to prevent or delay end-stage renal diseases in type 1 as well as type 2 diabetes. Deterioration of retinopathy in diabetes also appears to be retarded by ACE inhibitors. Now adverse effect: hypotension, hyperkalemia, cough, rashes, urticaria, dysgeusia, headache, dizziness, nausea, vomiting. Now angiotensin antagonist. Drugs: losatran, telmisartan, olmesartan, irbesartan, candesartan and valsartan. Losatran. Losatran blocks TXA2 anti-aggregant effect, decreases insulin resistance, decreases portal pressure used in treatment of portal hypertension, increases uric acid excretion. That's why it is used in treatment of gout. Now, its mechanism of action. Angiotensin receptor blockers competitively inhibits the binding of angiotensin to 81 receptor subtypes and blocks its effects. Now, its uses. First, hypertension. Losatran and other ARBs are now first-line drug with less side effect compared with AC inhibitors. No additional effect has been obtained by combining an AC inhibitors with ARB in treatment of hypertension. Congestive heart failure. ARBs offers clear-cut symptomatic relief as well as survival benefits in CHF, MI. The evidence so far indicates that utility of ARBs in MI, including long-term survival, is comparable to AC inhibitors. Diabetic nephropathy. ARBs are renoprotective in type 2 diabetes independence of BP lowering. Many ARBs are first choice of treatment now. Now, direct renin inhibitors. Aliskiren, used in treatment of renal and cardiovascular diseases. Mechanism of action: competitively block the binding of angiotensin to catalyst site of renin. As a result, inhibition of RAS occurred. Angiotensin 1 and 2 levels fall in dose dependent manner. Pharmacokinetics. Administered oral, but viability is very low due to active exclusion of absorbed drug by P-glycoprotein. Adverse effect: dyspnea, abdominal pain, loose motions, headache, dizziness, acute hypotension, hyperkalemia, cough, and angioedema. Now, question and answers. First, which of following is not AC inhibitor drug? Captopril, lisinopril, ramipril, or losatran? So the answer is losatran because it is not AC inhibitors. It is ARBs. Second, in hypertension, which drug besides lowering blood pressure arrests and even reverse cardiac hypertrophy? First, AC inhibitors, beta blocker, calcium channel blocker, or diuretics. Answer is AC inhibitors. Third, AC inhibitors causes hyperkalemia when interacts with potassium sparing diuretics, lithium, NSAIDs, or none of the above. Answer is potassium sparing diuretics. Fourth, shortest acting AC inhibitors: captopril, lisinopril, enalapril, or fosinopril. Answer is captopril. Which AC inhibitors is preferred in hypertensive emergency? Oral enalapril, captopril, IV enalapril, or losatran? Answer is IV enalapril. Thank you.